Okay, our final but not least presenter is Michaela Lotz. So Michaela is a wife and mother who has been living and working at Madwaleni Hospital in the rural Eastern Cape for the last 8 years. I have always had a special interest in child health, but since starting and completing a postgrad diploma in community and general pediatrics, have become better equipped and inspired to advocate more for rural children in our sub-district. And I've had the privilege of knowing Michaela for a few years now. And I think one of the successes we definitely have in our CP services is having great doctors like Michaela who help us in setting up our programs and just supporting us. Oh, I still say us, and it's been 4 years. I also just have to say, by the way, I might have started, but Ashley's been there the last 6 years. So she's whatever the CP program is now. That's also yay to Ashley.
The right level. Ooh. Okay. Hi, everyone. Like Tandy said, I am Michaela Lotz, and I've been working at Madwaleni since 2014. When we first arrived at Madwaleni in 2014, we had a really limited neonatal service, and we were pretty much managing neonates in our maternity ward, our sicker babies in the delivery room, and we were transferring anyone that required more than antibiotics and phototherapy. A lot has changed since then, and this is just a small part of that story. So I'm going to start out with the context of where we are in the rural Eastern Cape, a little bit about the motivation for advocating for surfactants specifically, and then a little bit about the advocacy process, our first year of having surfactants available, and then some take-home messages. So to start, it's good to know that the complications of prematurity make up almost 50%, or made up almost 50% of neonatal mortality in the perinatal PIP data in 2016. And out of this, recommendations like the happiness strategy were suggested, and they really suggested that improving your care at a district hospital level is important in improving neonatal mortality. And so that's where we ended up with this as our current Madwaleni service, with lots of help from our DCST, our Matole DCST, that Jenny Nash is part of, as well as previous staff at Madwaleni that have set up our high care unit since 2018. And we've had nasal CPAP since 2018 as well. And we also have specific nursing staff for neonates now, which we didn't have before. And we have senior clinical staff now at Madwaleni, and we have family medicine specialists and registrars and MOs with neonatal experience. And so that has really helped. Our stats at the moment, our deliveries in 2021 were about 1,600 deliveries, and it's rising. Our deliveries are getting more every year. Of those, 10% are low birth weight babies, less than 2.5 kilograms, and our early neonatal death rate is 5 per 1,000 live births, which is about half of the provincial and national numbers. Yeah, so where does surfactant fit into this? Our neonatal service had definitely improved, but in the end of 2020, we were sitting in a place where prem babies. So surfactant replacement therapy is not a standalone therapy, it's part of a package of care. And that also includes good antenatal care and corticosteroids, preventing hypothermia through KMC, and then the management of respiratory distress syndrome, which used to be known as hyaline membrane disease. The most important part of that is nasal CPAP, and then surfactants also forms part of that. Okay, so outcomes are better when surfactant is given early. So that's within the first 2 hours of birth, and that's as opposed to prophylactically and late. And it has been shown to reduce mortality and lower the risk of chronic lung disease in respiratory distress syndrome. It reduces the need for mechanical ventilation, which has implications for needing an NICU. And then Cochrane review has also shown that it reduces severity of illness in meconium aspiration syndrome. This is a really cool pyramid that came out of a study done in Cape Town, looking specifically at respiratory interventions for respiratory distress syndrome in low middle income countries. They did modeling and basically showed that what surfactant adds is it reduces mortality rates of infants on the ones on CPAP by a further 33%. Yeah, so for our neonates at Madwaleni, if they needed surfactant, basically they had inequitable access to it because it was sitting at our referral facilities. And this became a violation of their rights. So their rights to life, survival, development, their right to access health services that were according to their need, and also a right to not be discriminated on the basis of where they were born. So this, since I took this screenshot, we've had some roadworks and our road transportation time has actually improved. But basically our transfer delays are multifactorial, and they are due to an overburdened referral system where they're limited high care and neonatal ICU beds, and really delays from our EMS where there are really limitations on availability of advanced paramedics for these transfers. Yeah, and since this screenshot as well, we actually don't have air transfer available from our facility anymore. So it's only the road for us. And so out of this information, and basically I was doing a diploma where we did a child rights and advocacy module, and I decided that this was an advocacy need that I could look at. Yeah, so advocacy, people at this conference speak about it a lot, and a whole lot of different activities fall under advocacy. But to really simplify it, it's about convincing people to do something to improve the well-being and health of a child, a community, a patient. Yeah, so if you break it down into really a simplified approach, this is a really nice cycle. It starts with understanding the problem, identifying solutions, developing an advocacy strategy, which really involves thinking about who your target audience is, who's going to be able to actually do the things you want them to do, and has the power to make the changes that you need. And then thinking clearly about what your goals, objectives, and what your message is. And then the last step, taking action and monitoring progress. So my understanding the problem began with looking at a file review. So I did an audit of the preceding year, and I looked at all the babies that we transferred and the deaths, and there were 16 in total. And basically out of that, realized there was a need for surfactants at our level hospital. But mostly the biggest thing that was highlighted was the really long transfer delays, which was an average of 26 hours from our first discussing a patient to the arrival of EMS at our hospital. Yeah, so the next part of understanding the problem was then figuring out the policy around procurement of surfactant, and basically the standard treatment guidelines and essential drugs list, medicine list. It's a requirement that surfactant is given in consultation with a paediatrician. And as a district hospital, we don't have an on-site paediatrician, and we don't have a paediatrician as part of our DCST either. And so this had really caused difficulties in procuring surfactants ourselves. And so understanding this, speaking to our DCST, speaking to another hospital down the road in the same district that had managed to get surfactant. All of this together helped me to understand that the person that I needed to be speaking to was the head of neonates at our referral facility. And the next part was then the key message, and this broke down into 4 parts: that surfactant reduces mortality and morbidity, that we have long transfer delays that limit access, that Madwaleni has capacity to be giving surfactant, and that we needed our referral facility to endorse that in order to make it possible. When developing the advocacy strategy, some of the specific things that were thought of was that we used our local data to show that we had a need and to show the problem of the transfer delays. Part of our strategy was to make sure that we could build the confidence in surfactant being given at our level hospital. And so this was done with a success story, which is always good. Of a very low birth weight baby that managed to get surfactant and was managed definitively at our level hospital. And then also the stories of other hospitals that were giving surfactant. Butterworth is in our district, has a similar road transportation time to their referral facility. They're much busier, but they have similar facilities. And they were in relationship with their referral hospital, they were also giving surfactant. There were lots of, Western Cape has its own protocol for giving surfactant at district hospitals. And we use these examples to show, to build confidence in surfactant being used at our level. We knew from early conversations that we really needed to focus on safety of giving the surfactant. And so part of it was making sure we had a protocol, making sure we were trained, making sure that surfactant was always given with senior cover, and also making sure that we were going to monitor our surfactant use, and we do that through a shared document. And basically focusing on benefit to patients, benefit to the referral facility, rather than assigning blame and making enemies. So looking back at our first year, despite some ongoing challenges, surfactant has become part of our service. We have given surfactant mostly to prems with respiratory distress syndrome, but we've also given to 2-term babies with meconium aspiration. Most of our administrations, 86% of them, were using the LISA method, the less invasive surfactant administration method, using an NG tube, keeping the baby on CPAP. There was one case when we didn't have an adequate amount of surfactant for a baby, which is the dose being 4 mils per kg of Savanta. And 2 of our neonates required transfer and were able to be transferred. One died at the referral facility, and the other one was down referred and discharged later. As you can see, the significance of birth weight had a big effect on our outcomes, and none of our extremely low birth weight babies survived, whereas all of the more than 1.5 babies survived to discharge, and 43% of our very low birth weight babies survived to discharge. So this is a lovely quote saying all reasonable measures should be put in place to ensure rural communities' access is not limited by their place of residence. And for us at Madwaleni, this was really a reasonable measure to try and address some of the inequitable access in a small way for our rural community that we serve. But that being said, it may not be a reasonable measure for all facilities and all communities. And so this is different at each of our different facilities. My take-home messages then are that understanding the problem is really the first step. And I think if you're wanting to be effective, understanding the problem and who you actually need to speak to and what the problem is can make the biggest difference. My next point, that ongoing challenges are okay. They can be expected. It's not always smooth, but that's part of working in rural areas and building resilience, so don't give up. The next part is same but different. So we are all rural, working in rural areas, but different provinces, different facilities, and our communities have different advocacy needs. And so, yeah, finding the thing that needs to be advocated for in your environment is important. And then just an encouragement, but I feel like there are lots of advocates in the room, is to go be an advocate in your community. Yeah, it really, seeing change and seeing improvements in services is really rewarding, and it really adds meaning to the work that we do. Thanks. Sorry.
Okay, thanks, Michaela. Achieving something like surfactant and the NICU unit, I think, has been a huge success. And I really like that you're doing advocacy, and it's an ongoing problem. Is like, yeah, I think that's great. So thank you for that. Thank you for everyone for this session.